This class is on anti-amoebic drugs. Antiaerobic drugs are integral histopatica. It occurs due to the fetal contamination of food and water. There are two stages in the development of parasite. This is from trophozoite. This is the intestinal lumen. So this is form. This is the cis form, and this is the trophozoite form. So the trophozoite form can enter the bloodstream through the portal vein. It can reach liver, and it can cause acute amoebic hepatitis. Rarely, the trophozoite form can get encysted, and liver abscess can occur. The intestinal form can remain as asymptomatic. The cyst passes without any symptoms, or it can invade the intestinal mucosa and cause acute amoebic dysentery characterized by blood in stools. Coming to the classification of anti-amoebic drugs, they are broadly classified into tissue amoebicides and luminal amoebicides. Tissue amoebicides are further classified into drugs that can act on both intestinal forms and extraintestinal forms, and drugs that are used for extraintestinal amoebiasis only. So for both intestinal and extraintestinal amoebiasis, two groups of drugs are used: nitroimidazoles and alkaloids. Nitroimidazoles include metronidazole, tinidazole, and zigmidazole. Alkaloids include emetin and dihydroemetin. Tissue amoebicides for extraintestinal amoebiasis only is chloroquine. The luminal amoebicides include amide, 8-hydroxyquinolines, and antibiotics. Amides are diloxanide, furoate, and metronidazole. 8-hydroxyquinolines include quinidochlor and idoquinol. Antibiotics include tetracycline and parabomycin. So the luminal amoebicides act in the intestinal lumen. So this include diloxanide, parabomycin, and idoquinol. The tissue amoebicides include emetin and chloroquine. Luminal and tissue amoebicidal action are present for metronidazole, tinidazole, and onidazole. Coming to the prototype drug in the nitroimidazole group, that is metronidazole. So it acts on anaerobic protozoa. It has got broad spectrum cell activity against Antiamoeba histolytica, Trichomonas vaginalis, and Giardia lamblia. It also acts on anaerobic and microaerophilic bacteria like Bacteroides fragilis, Clostridium perfringens, Clostridium difficile, Helicobacter pylori, Campylobacter, and anaerobic streptococcus. Coming to the mechanism of action of metronidazole. Metronidazole is not active against aerobes. It has got selective toxicity to anaerobic pathogens and microaerophilic organs. After entering the cell by diffusion, nitro group is reduced by certain redox proteins operating only in anaerobic microbes to a highly reactive nitro radical. This nitro radical exerts cytotoxicity. Nitro radical competes with biological electron acceptors of the anaerobic organism for the electrons generated by pyruvate ferredoxin oxidoreductase enzyme pathway of pyruvate oxidation. Thus, energy metabolism of anaerobes is disrupted. So, this is the pyruvate ferredoxin oxidoreductase enzyme pathway. So, pyruvate gets oxidized to acetylcholineamine with the help of pyruvate ferredoxin oxidoreductase enzyme. So, during this step, oxidized ferredoxin gets converted into reduced ferredoxin, and here you can see this is the nitro radical of metronidazole. So, this nitro group gets converted into highly reactive nitro radical. So, here this acts as an electron sink. It will accept electrons and it exerts cytotoxicity. So, the nitro group in metronidazole is reduced to highly reactive nitro radical. It will compete with biological electron acceptors. Nitro radical acts as an electron sink for the electrons generated by the pyruvate ferredoxin oxidoreductase pathway. And thus the energy metabolism in anaerobes which lacks mitochondria are disrupted. So why they are not effective in the presence of oxygen? Because oxygen will compete for the electrons. So in presence of oxygen, metronidazole is ineffective. Oxygen will compete for the electrons generated by pyruvate ferredoxin oxidorobacterial particle. Now coming to the pharmacokinetics, metronidazole is completely absorbed from the small intestine. So very little drug reaches the large intestine. That's why it's not effective against the intestinal forms. Metronidazole has got wide distribution in our body. The half-life is 8 hours. The important adverse effects, most common are the gastrointestinal symptoms like anorexia, nausea, abdominal cramps. Also an unpleasant metallic taste occurs. Can also cause headache, glossitis, dryness of mouth, rashes, urticaria and flushing occurs in allergic individuals. And prolonged use of metronidazole can cause peripheral neuropathy and CNS effects. Seizures occurs at high dose. Leukopenia can occur. Thrombophlebitis of injected vein is another adverse effect. Because of this, metronidazole is contraindicated in neurological disease, blood dyscrasia, in first trimester of pregnancy because of its mutagenic potential, and it should be used in chronic alcoholics with caution because of disulfiram-like intolerance. Important drug interactions of metronidazole. It causes disulfiram-like intolerance. So the patient, if they consume alcohol while on metronidazole, they will develop distressing symptoms of headache, nausea, facial flushing, weakness, sweating, chest pain, extreme vomiting and difficulty in breathing. So the patient should be advised not to consume alcohol while on metronidazole. Enzyme inducers like phenobarbital and rifampicin will reduce the therapeutic effect of metronidazole. Now coming to the uses of metronidazole, important one is amoebiasis. For invasive dysentery and liver abscess, dose is 800 mg thrice daily for 7 to 10 days. In severe cases of amoebic dysentery or liver abscess, 500 mg infused IV slowly over 6 to 8 hours for 7 to 10 days or till oral therapy can be instituted. For mild intestinal disease, 400 mg thrice daily for 5 to 7 days. Second use is giardiasis. 400 mg thrice daily for 7 days, or an alternative regimen is 2 gram per day for 3 days. For trichomonas vaginitis, it is the drug of choice. 2 gram single dose is effective. For anaerobic bacterial infection following colorectal or pelvic surgery, appendicectomy, endocarditis, metronidazole can be given in combination with gentamicin or third generation cephalosporin. Pseudomembranous enterocolitis caused by Clostridium difficile, 400 to 800 mg twice daily or thrice daily for 10 to 14 days is effective. For Helicobacter pylori gastritis or peptic ulcer, 400 mg thrice daily along with the triple drug therapy with amoxicillin, clarithromycin and proton pump inhibitor. Acute necrotizing ulcerative gingivitis or trench mouth, metronidazole is the drug of choice. 200 to 400 mg thrice daily is combined with tetracycline or erythromycin. Usually, trench mouth is caused by mixed flora of anaerobes like fusobacteria, spirochetes, and bacteroids. So here it causes rapid disappearance of organism and symptom relief. Coming to the congeners of metronidazole, first is tinidazole. It has got long half-life, so it is effective even if it is given once daily. It has found to produce higher cure rates in amoebiasis, lower side effects like metallic taste, nausea and rash, and it is given for intestinal amoebiasis and amoebic liver abscess at a dose of 2 gram once daily for 3 to 6 days. For trichomoniasis and giardiasis, 2 gram single dose is effective. Also for anaerobic bacterial infection, 2 gram orally followed by 0.5 gram twice daily for 5 days. Secnidazole has rapid absorption and slower metabolism, so it has got very long half-life of 17 to 29 hours. Onidazole has a half-life of 12 to 24 hours. Satranidazole has a half-life of 14 hours. It is better tolerated. because it does not cause nausea, vomiting, metallic taste, disulfiram-like reaction, and neurological symptoms. Coming to the alkaloids, emetin and dihydroemetin. Emetin will cause emesis and it is cardiotoxic and cumulative, whereas dihydroemetin is less cardiotoxic and less cumulative. These alkaloids are effective against the tissue trophozoites of Entamoeba histolytica. Mechanism of action is by inhibiting the protein synthesis. They do not act on cyst. Adverse effects are, first is GIT, nausea, vomiting due to central and direct effects, abdominal cramps, diarrhea, cardiac toxicity, arrhythmias, congestive heart failure, neuromuscular blockade, causing muscle weakness and discomfort like myositis. Coming to the next drug, that is chloroquine. It kills the trophozoites. Chloroquine reaches high concentration in the liver. Therefore, it is used for the treatment of amoebic liver abscess. And it does not have any effect in invasive dysentery. Coming to the next group, that is luminal amebicide. Diloxanide furoate is commonly used as the luminal amebicide because it is highly effective. It directly kills trophozoites responsible for production of cyst. Diloxanide furoate is effective in mild intestinal amoebiasis and asymptomatic cyst puzzles. Adverse effects include flatulence, nausea, and rashes. Nitazoxanide is a prodrug. It gets converted into its active form, that is disoxanide. It is used for treating giardiasis, amoebic dysentery, and it is found to be highly effective in treatment of cryptosporidiosis caused by Cryptosporidium parvum in AIDS patients. The next group is 8-hydroxyquinoline. It is effective against Entamoeba, Giardia, Trichomonas, some fungi like dermatophytes, Candida, and some bacteria. It kills the cyst-forming trophozoites in intestine. It doesn't have tissue amoebicidal action. It is used in the treatment of intestinal amoebiasis as an alternative to diloxanide furoate, and also in the treatment of giardiasis, local treatment of monilial and Trichomonas vaginatus, fungal and bacterial skin infection. 8-hydroxyquinolines include quinidochlor and idoquinol. The adverse effects are nausea, transient loose and green stools, pruritus, can cause goiter due to prolonged therapy. Iodism occurs. The symptoms are furunculosis, inflammation of mucous membrane. It occurs due to chronic iodine overload, and prolonged or repeated use of high doses causes a neuropathic syndrome, subacute myelooptic neuropathy, which can result in blindness. So India has banned this compound for pediatric patients because of the incidence of blindness. Moving to the next group, that is tetracyclines. It can directly inhibit amoeba at high concentration, and older tetracyclines are incompletely absorbed in the small intestine. Therefore, it can reach the colon in large amounts and inhibit the bacterial flora with which Entamoeba live symbiotically. Thus, they indirectly reduce the proliferation of Entamoeba in the colon. So, it is used in the treatment of chronic, difficult to treat cases with only the luminal cycle and little mucosal invasion. Now coming to leishmaniasis, it occurs due to the bite of female sandfly phlebotomus. Visceral leishmaniasis is fatal unless it is treated. The regimens for visceral leishmaniasis include amphotericin B-deoxycholate, liposomal amphotericin B, and another drug is miltefosine. It has to be given for 28 days. In adult more than 12 years with weight more than 25 kg, 100 milligram is given every day. In adults more than 12 years with weight less than 25 kg, 50 milligram is given per day. In children 2 to 11 years, 2.5 milligram per kg per day is given. Amphotericin B is the second line treatment under National Vector-Borne Disease Control Program for visceral leishmaniasis. In WHO regime, it is a drug of choice. Miltefosine is a drug of choice as first-line treatment under NVBDCT. It acts by interfering with lipid metabolism of the parasite. Adverse effects are anorexia, vomiting, diarrhea, skin allergy, and rise in hepatic transaminase. Coming to the drugs for giardiasis, it includes metronidazole, nitazoxanide, quinidochlor, furazolidol. Drugs for trichomoniasis. The drugs used orally are metronidazole 400 mg thrice daily for 7 days, or tinidazole or secnidazole. Repeat course has to be given after 6 weeks. Drugs given intravaginally are diiodohydroxyquine, quinidochlor, and povidone. The regimen for acute amoebic dysentery is metronidazole 800 mg thrice daily for 7 to 10 days, plus luminal amoebicide, diloxanide furoate 500 mg thrice daily for 5 to 10 days. Metronidazole produces quick symptomatic relief, kill trophozoites in 5 to 10 days, and adjuvant measures should be given for diarrhea and abdominal pain. Luminal amoebicide is given to ensure complete eradication of entamoeba from colon and to prevent the carrier state. In mild intestinal amoebiasis or asymptomatic cystic metronidazole 400 mg thrice daily for 5 to 7 days along with luminal amoebicide. In amoebic liver abscess, metronidazole 800 mg thrice daily for 10 days. In serious cases, 500 mg solo IV infusion for 10 days along with luminal amoebicide. It is a serious disease. Complete eradication of trophozoite is essential to avoid relapse. In case of large abscess, aspiration has to be done. Luminal amoebicide is given later to finish the intestinal reservoir of infection. That's all. Thank you.